Welcome back to Clinical Reasoning Rounds, Episode 2. If our first set of cases were loud, these 5 are the quiet ones, presentations that whisper. We'll explore history, exam, and data, then pause for you to commit to a diagnosis before the reveal. As always, this video is for education only, not medical advice. Let's get started. Every case follows 6 essential beats. We start with history, where most diagnoses hide, and move through the examination and investigations. Then, the most important part, you decide. I will pause the video so you can commit to your own diagnosis. Finally, we'll cover the reveal and the clinical pearls. Let's look at the board. Here is our case board. We have 5 patients, 5 clinical stories, and 5 diagnoses that reward careful listening. We'll see everything from unexplained weight loss to back pain and fever. Keep your pens ready. We have a lot of ground to cover today. Case 1. A 66-year-old retired nurse presents with 4 months of fatigue, breathlessness, and 6 kilograms of weight loss. Crucially, her appetite is completely normal. In medicine, when a patient loses weight while their intake remains steady, it is a warning sign that requires an immediate and thorough investigation. Looking deeper into her history, she reports an altered bowel habit over the last 2 months, fluctuating between constipation and her normal routine. She has no pain, no bleeding, and no relevant family history, but her social history is notable for 48 years of smoking. We are building a profile of a patient who needs a focused search. Her physical examination is largely unremarkable, save for slight pallor. Her blood pressure is slightly elevated, but the rest of the check is clean. It is vital to remember that a normal examination does not rule out serious pathology. Given her weight loss, we must look closer, starting with her blood count. Her blood work reveals microcytic hypochromic anemia, small, pale red cells. This is the classic signature of iron deficiency. In a postmenopausal woman with no visible blood loss, this finding is highly concerning for an occult source of bleeding. It is a critical piece of our diagnostic puzzle. Pause the video here. Based on the clues, iron deficiency anemia, a change in bowel habit, and significant weight loss, what is your most likely diagnosis? Also, consider your plan of investigation. Where is the iron going? Formulate your answer, then continue the video to see if your reasoning aligns with the reveal. The diagnosis is carcinoma of the colon. A tumor in the sigmoid colon can bleed slowly and invisibly, leading to chronic iron deficiency without dramatic gut symptoms. The rule to remember: in any man or postmenopausal woman, iron deficiency anemia indicates gastrointestinal blood loss until proven otherwise. Her bowel changes were the final clue. The workup confirmed a sigmoid tumor via colonoscopy. Staging imaging showed no evidence of spread. This case highlights why we investigate the gut for rectal bleeding, unexplained anemia, or persistent changes in bowel habits. Always consider smoking as a risk factor, and remember to look at both the upper and lower gut when iron deficiency is unexplained. Our patient's story ended well. The tumor was low-grade and treated surgically before it could spread. Her outcome serves as a perfect example of why these red flags matter. Remember these 3 pearls. Gut cancer can present quietly, unexplained iron deficiency requires a full evaluation, and weight loss with a normal appetite is always a search, never a shrug. Moving on to case 2, our patient is a 45-year-old chef. He presents with a paradoxical clinical picture. He is losing overall body weight, yet his waistline is expanding. He also reports chronic morning nausea and vomiting, combined with swelling in his ankles. He is shrinking and growing at the same time. Let's look closer. His history provides more context. The paradoxical weight change, combined with nausea and morning vomiting, suggests a systemic or metabolic process. He reports a significant intake of alcohol. Living alone with unknown family history, we have to carefully piece together his clinical background to understand what is happening to his health. On examination, he has clear signs of advanced liver disease, spider nevi, ankle edema, and a distended abdomen with shifting dullness and a fluid thrill. These are classic signs of ascites. While he is losing muscle mass elsewhere, fluid is pooling in his abdomen. His skin and his belly are telling us a very clear story. The blood work reveals a liver panel in distress. While the enzymes are elevated, the true insights come from the lower albumin and high INR, which indicate the liver's synthetic function is failing. Low platelets suggest portal hypertension from a congested spleen. And the high MCV is a classic sign of chronic alcohol use. The labs confirm our suspicion. Pause the video. 2 questions here, and the second is the real test. First, what is the diagnosis and its effect on his abdomen? Second, one part of his reported history simply doesn't fit the clinical findings. Which part is it, and why? Weigh the clues, commit to your answer, and then we'll move to the reveal. The diagnosis is alcoholic cirrhosis with portal hypertension. The inconsistent detail was his reported intake. 15 units a week cannot cause such advanced signs. He later admitted to 50 units weekly. Morning nausea was his tell. Ultrasound confirmed the damage, ascites and a shrunken liver. Remember, physical signs often tell a more honest story than a patient's initial history. Managing this patient requires an immediate safety checklist. Protect his brain with IV thiamine to prevent wernicke's, and use benzodiazepines to manage withdrawal safely. Perform a diagnostic tap on the ascites to rule out infection, and use vitamin K to support his clotting. Long-term, manage his fluid with diet and diuretics. Tragically, this case ended with a complication from esophageal varices. It serves as a stark reminder that in alcoholic liver disease, the single most important variable for prognosis is absolute abstinence. As you carry these pearls forward, remember that enzymes measure noise, but albumin and platelets measure function. Read the signs, and always listen with empathy. Case 3 introduces a 22-year-old with fever and malaise. But there is a vital detail. 2 weeks before these symptoms began, he suffered from aching joints. In medicine, the sequence of events is as important as the symptoms themselves. The joint pain was our first, quiet clue of something more serious developing. Reviewing his history, the 2-week joint pain preceded his fever and vomiting. His exposures include occasional drug use and potential sexual risks. While he reports a negative HIV test, we must approach all such information with professional skepticism. Every detail provided here is about to become a piece of our diagnostic puzzle. Examination reveals a fever and mild jaundice with right upper quadrant tenderness. The lab results are striking. Extremely high transaminases, 16 times the normal limit, while the duct enzymes are only mildly elevated. This pattern points us directly toward a specific type of injury. We must determine which family of liver disease this falls into. There are 2 main families of liver injury. The obstructive family is marked by high duct enzymes, like alkaline phosphatase. The hepatocellular family, seen here, is dominated by high transaminases. This suggests cell-level damage from a virus, a toxin, or a drug. The high ALT level is the key indicator for our next step. Pause the video again. Based on the pattern of injury and the timeline, joint pain followed by fever, what is your primary diagnosis? What details should you independently verify, and what other factors could mimic this presentation? Take a moment to think through the possibilities, then continue for the reveal. The diagnosis is acute hepatitis B. The joint pain was a classic immune complex prodrome. We confirmed this with IgM antibodies. While we must consider other viruses like A or C, or drug-induced injury, this presentation is hallmark. Remember, always verify critical history like previous HIV results, as seroconversion can present similarly. Management is largely supportive, as most acute cases resolve on their own. Our role is to monitor his liver function, ensure absolute avoidance of alcohol or toxic substances, and protect the household. Offer vaccination to his contacts, report to public health, and use this clinical encounter as a chance for non-judgmental counseling. Our final pearls from Case 3, arthralgia preceding jaundice, is a classic viral clue. The ALT to ALP ratio is your most reliable tool for sorting liver disease at the bedside. And lastly, never accept a patient's reported negative test as absolute truth. Verify it yourself. We have 2 kidney cases left to explore. Case 4. We have an 85-year-old woman presenting with a 6-month history of exhaustion, nausea, and weight loss. These are vague symptoms that could suggest many conditions. However, the addition of generalized itching and muscle cramps in the last 4 weeks gives us a much more specific clinical lead to follow. Looking at her context, she has a significant history of hypertension and prior strokes, which have impacted her mobility. She lives alone, managing with support. These background details are essential. A patient's living situation and history often inform the speed and nature of their decline. Now we turn to the physical exam. Her exam shows persistent hypertension and signs of long-standing vascular damage. The lab results are truly alarming, showing severe kidney failure. With urea and creatinine levels this high, and symptoms like itching and cramps, we are looking at the classic metabolic consequences of uremia. We need to identify the underlying cause immediately. Pause the video. Question 1. What is the diagnosis? Question 2 is the connoisseur's question. Is this organ failing acutely, over days, or chronically, over months? Crucially, which findings on this page date it for you? Your clues: urea at 7 times normal and creatinine at 6 times, an anemia of normal-sized cells, and that bone mineral trio. Commit, then we'll decode it. The diagnosis: end-stage chronic kidney failure. Her symptoms: fatigue, nausea, weight loss, itching, cramps, form the classic cluster of uremia. Why did she present so late? Kidneys have huge reserves. Symptoms often appear only once filtration falls below 15%. Urea and creatinine confirm failure but cannot date it. The chemistry, however, tells a long story. 3 fingerprints prove this is chronic. First, her anemia. Healthy kidneys make erythropoietin. Months of failure mean months of low hormone, leading to her normocytic anemia. Second, the bone chemistry. Failing kidneys can't excrete phosphate or activate vitamin D, causing calcium to fall and ALP to rise. Third, her ultrasound showed 2 small scarred kidneys, shrunken by time. If you order one investigation for unexplained kidney failure, make it the ultrasound. 1 scan, 4 answers. Size tells you acute versus chronic. Obstruction shows potential reversibility. Cysts suggest inherited disease, while asymmetry hints at vascular issues or childhood reflux. Her kidneys point toward long-term hypertension or a smoldering, undiagnosed primary glomerulonephritis. Management means replacing what the kidneys can't do: control blood pressure, manage phosphate and vitamin D, and provide erythropoietin. Then, the dialysis conversation. At 85, with her comorbidities, conservative care focusing on comfort and quality of life is a valid, often kinder, road. Remember, silent until 15%, use old results to date decline, and always ultrasound first. Our final case moves fast. A 27-year-old woman arrives in the emergency department looking genuinely ill. 2 days ago, a fever and back pain began. Both have climbed relentlessly. In the last 6 hours, she has vomited twice. Back pain plus high fever in a young woman. The stakes are immediate, and one detail from 3 months ago completes the story. Her history is brief and steep. 2 days of worsening back pain and climbing fever. She hasn't been able to keep fluids down for 6 hours. The telling detail? An episode of simple cystitis 3 months ago. Notice she has no current burning on urination. Do not let that reassure you. Let's look at the examination. She is flushed and unwell. Temperature is 39.5. Her pulse is racing at 120, and her blood pressure is drifting low. The abdomen is tender, with significant pain in both loins, the area over the kidneys. This is sepsis physiology until proven otherwise. The urine is about to point us at the source. Her blood work shows a high white cell count and CRP, confirming a systemic fight. The urine dipstick is the key. Protein, blood, and most importantly, nitrites are present. Common gut bacteria convert nitrates to nitrites, so a positive result means bacteria are living in her urinary tract. Microscopy confirms this with high levels of both white and red cells. Pause the video one last time. First, what is the diagnosis? Second, what is your management plan? And what specific scan is vital to perform by tomorrow morning? Consider the clues: high fever, flank tenderness, and the systemic signs of distress. What is the one complication you absolutely cannot afford to miss? We'll reveal the answer next. The diagnosis is acute pyelonephritis. It is a bacterial infection of the kidneys, often ascending from the bladder. It is more common in women and can be mimicked by other acute abdominal conditions. Crucially, don't be fooled by the absence of lower urinary symptoms. Without treatment, this can progress rapidly to septic shock. Manage this in 4 steps. Culture blood and urine before starting antibiotics. Support her with IV fluids and order a renal ultrasound within 24 hours. Why? You must exclude obstruction. Infection plus obstruction equals pyonephrosis, pus under pressure, which is a medical emergency requiring urgent drainage. Treat for at least 2 weeks to avoid relapse. 3 final pearls. First, pyelonephritis does not need bladder symptoms to exist. Fever and loin pain are enough. Second, every febrile kidney infection earns an ultrasound within 24 hours to exclude obstruction. Third, treat for a full 2 weeks to prevent scarring. That covers our cases. Let's summarize the habits of mind we've practiced today. We've walked through 5 cases, each teaching a different habit of mind. Remember, investigate iron deficiency, let physical signs outrank stories, respect the order of symptoms, look for biochemical fingerprints in chronic illness, and never ignore fever with possible obstruction. Every patient is a study in careful observation, questioning, and verification. Rounds are complete. You've navigated colon cancer, alcoholic cirrhosis, acute hepatitis B, chronic kidney failure, and pyelonephritis. These cases were solved by listening to the quiet details. If these rounds helped you, share this video with a colleague and subscribe. New patients arrive in the next episode. For education only, not medical advice. See you next time.